Good morning, all. Thanks for being here. It's nice to be the first speaker because you don't fall asleep so easily. At least I don't, anyway. So I have a lot to go over. Many of my slides are in your book, but I did update them a little bit since the book was published, so you'll need to bear with me because I tend to have last-minute brainstorms. I'm going to talk about Lyme disease, the Borrelia itself. I'm not going to be talking about the co-infections. Dr. Horowitz will do that. What I also want to do today is begin with a little bit of the political background and why there's controversy in Lyme disease, how that whole thing developed and where it stands today. Then I'll talk about the illness from kind of a biological point of view. One of the things that you will find in your practice, if you haven't already, is that everybody's different. And you can't use one regimen to fix everyone. So what I'd like to try and do today is give you the kind of background where you feel confident in you making your diagnosis and confident in the kind of ways you can approach treatment so you have options and you can tailor your treatment exactly to your patient as best you can. So we'll get started. I don't have any conflicts of interest to mention. You know, early on in the United States, Lyme was recognized, but we didn't know it was Lyme at the time. Now, if you go back to the late 1800s, you can see histories of Lyme in Europe. But in America, for example, Dr. Robin is an internist in Montauk, New York, where I was raised, eastern Long Island. And he saw what are now known as EM rashes, and he gave these patients penicillin, and the rashes cleared up. He also described what's called Montauk knee, which is a Lyme monoarthritis. In 1970, Dr. Scrementi from Wisconsin, a dermatologist, actually wrote a paper on EM rash in the United States. He also treated that with penicillin. So even back in the 60s and 70s, people were recognizing Lyme and using antibiotics. Lyme became Lyme disease after about 1975. A mom, just like many of the activists here in this organization, had all these friends and relatives and neighbors along the same street with the same symptoms, with the arthritis, Bell's palsy, all these things. And for years, she was hounding the CDC to do something about it. Finally, in 1975, they sent Dr. Steer to Connecticut, and he did a study and published on 51 patients. His background was, and is, he's an immunologist and a rheumatologist. So when he saw this, in his rheumatologic point of view, this was an arthritic condition. He didn't think it was an infection. He treated the patients with anti-inflammatories like steroids and aspirin. 1982, Dr. Bergdorfer came on the scene, collecting ticks from Shelter Island, which is incidentally also on Long Island, not too far from Montauk, and he found the germ they call Borrelia burgdorferi, they're named after him. So this is when it became known that Lyme disease was caused by a spirochete. Now, what happened? When the discovery that this was a spirochetal infection was published, the group, including Dr. Steer and the others at Yale, decided, well, let's try treating them, but we don't know what to do. It's a new illness. So we'll use the treatment we use for other spirochetes, like syphilis, was 10 days of penicillin. And some of the things got better in the patients, but some of the things did not. So according to the books that I've read, and this is all reference, it's not just my opinion, they were unwilling to either publicly admit or believe themselves that their treatment failed. So they said, let's re-examine Lyme and see what it is. So they said, well, there are major symptoms of Lyme. They call that the Bell's palsy, the inflammatory arthritis, and the carditis. And if your treatment makes those three things go away, then it's successful. However, a lot of the patients, if not all of them, were left with aches and pains, fatigue, headaches, the brain fog, the tingles, and all the things you recognize as chronic Lyme. So they said, well, how could an infection possibly live after 10 days of antibiotics? So they said, we'll call these the minor symptoms and call it a post-Lyme syndrome, like an after the infection is cleared. So that's how they try to redefine Lyme to make it fit their results. Now, in retrospect, 10 days of penicillin G doesn't work for Lyme disease. And so what they basically did was they undertreated the patients, then tried to redefine the illness to account for what they found. If you look at the literature, now Dr. Steer did his studies in the early 70s or mid-70s, and not until the early 80s was it known to be an infection. So he had many years of seeing these patients over time. And you know, in over 90% of people who had Bell's palsy, it resolves without treatment. In 95% of people with chronic arthritis, it resolves without treatment. In over 90% of people with Lyme carditis, it resolves without treatment. So his major symptoms going away with his 10 days of penicillin wasn't any kind of treatment. It was just the natural history of the disease. But this is how the whole thing started. Now, what happened when I came on the scene in the mid-1980s, we gave 10 or 14 days of simple antibiotics, and some patients got a little bit better, but they would relapse. Others just didn't get better at all. But you know, how many times do you have to see the same pattern? You give someone an antibiotic course, they get better, you stop it, the same things come back. You give them the same antibiotics, they get better, they stop, same things come back. You know, after 50, 70, 100 patients like this, you say, wait, something else is going on. So to me, it looked like this wasn't enough treatment. I had to have proof. Alan McDonald came on the scene then. He's a very brilliant pathologist. He's still active in the Lyme field today, and he developed the first reliable blood culture for Lyme disease. And so if someone had active infection, he could actually take a blood sample, look under his high-powered custom-made microscope after culturing, and find the spirochetes. Now, he was in a hospital local to where I was, and so at the end of the day when I came home from work, on the way home, I'd stop by his lab and look at his microscope. And there I saw with my own eyes, these were spirochetes in my patient's blood. I saw it. They had Lyme disease. So not only did I see people who had seronegativity, in other words, a blood test showed no Lyme, but his test showed there they were. I also saw people with these so-called atypical presentations, like look like MS, look like Alzheimer's, and so forth, who actually had Lyme disease and responded to treatment. But more importantly, when we saw these patients who the Yale group said they're cured of the illness, now they have this rheumatologic post-Lyme syndrome, the cultures were positive. They weren't post-Lyme, they still had Lyme disease. It wasn't autoimmunity, it was still a treatment failure. So that's kind of how the divide began. Now, at the time in the 70s and 80s, two big public health issues came to America. One was HIV/AIDS, the other was Lyme disease. Because Lyme was originally studied by rheumatologists and was thought to be an arthritic condition before they discovered the spirochete, what the government did was they divided the research in half. The infectious disease group went to HIV/AIDS, and the arthritis group, immunologists, went to Lyme disease. So from that point forward, the focus from government research and funding of the universities also is that Lyme is an autoimmune condition. Simple antibiotics should treat it and get rid of it. Because the blood tests or serologies are immune-based, they have to be accurate, which of course we know they're not. And from that day forward, there's been this divide, and this basic knowledge using cultures showing that Lyme, in fact, is a persistent infection has pretty much been ignored. All right, so let's go into the biology of this. Some of you already know that it's really hard to treat Lyme disease, especially in someone who's had it for a long time. Now, why is that? First of all, the Borrelia that cause Lyme are immunosuppressive. They also cause defects in the signaling of B cells so that the innate immune system doesn't turn off. What that means is that the inflammatory cytokines are enhanced and the anti-inflammatory cytokines are decreased. So you have a persistent inflammatory reaction going on. The Lyme germ is unique because it can morph into different morphological forms. We've all seen these spiral-looking corkscrew things. These are the spiral form, but they can lose their cell wall, become L forms, also known as cell wall deficient forms. And these can also encase themselves in a cyst, which makes them impervious to treatment. So if they're in a hostile environment, such as being exposed to antibiotics or in the spinal fluid, they're going to form a cyst, stay protected. When the hostile environment clears, they come back into a spiral. We've seen videos of this. Another thing is they grow very slowly. You know, a normal bacterium like E. coli, for example, a staph or strep, the doubling time is measured in minutes. In Borrelia, it's measured in days. The doubling time is slow, consistent with, for example, tuberculosis. Now, the thing is, the slower the germ grows, the more treatment you need to get rid of it, and no one would treat tuberculosis with 10 days of antibiotics. Another thing about Borrelia, the story gets more complicated. They don't grow steadily like most bacteria. Like any other relapsing fever Borrelia, they go through periods of growth, then they go dormant. Then they grow, and then they're dormant. It turns out that when they're dormant, they're not affected by antibiotics. Antibiotics kill germs during their growth phase. So if you have a treatment regimen that's too short, and you don't hit all the spirochetes in their active growth phase, you're going to have a treatment failure. And the relapse regeneration cycle of Borrelia and Lyme is 4 weeks long. So here you see a 10-day course of antibiotics impossibly could not fix this. They also can go dormant and latent. McDonald, with his cultures, found dormancy as long as 10.5 months before they became active again and restarted the infection. And finally, these Borrelia have adapted to the host so well, they find protective niches. They can make biofilms, which are like gelatinous coatings that protect them from the immune system and from antibiotics. They dig themselves deep within tissues and ligaments where it's hard to get penetration of the immune system and antibiotics. So let me just show you some pictures. The one on the left, the little greeny things, that's what Borrelia actually look like from a blood culture. On the right comes from the National Institute of Health. This came from a urine specimen. And if you note, it's a fuzzy, hazy look. Well, that's not a blurry picture. This is the Borrelia secreting what's called an S layer, S for slime. I mean, it's very scientific. But this is the genesis of the biofilm that the Borrelia make. This is what happens when the Borrelia start to change. What you can almost appreciate that this, let me see, it almost looks like a spiral spirochete that's breaking up into little pieces. Believe it or not, that's exactly what's happening. Each one of these little dots will form an intact Borrelia. They become a cell wall deficient or L-form Borrelia. And then this is a cystic form. They coil up inside these little cysts. They get protected from the environment. They don't have surface antigens on these. So if you have an encysted Borrelia, your immune system is not going to even know it's there. And when the environment becomes less hostile, they'll come out of this cyst. And here's a picture of the Borrelia actually living deep within a ligament. You know, how is an antibiotic or the immune system going to penetrate that? It's an Achilles tendon. Now, if you look at the early studies on Lyme before the politics got involved, as I said, only 5% of people with Lyme get chronic rheumatoid-like arthritis, but almost all of them get the aches and pains. They call it an enthesopathy. What that means is an infection or inflammation of the ligaments and tendons where the muscles and joints attach. And if you see this on the slide, I'm pointing to the computer, I should point to this. I mean, if you see the spirochetes in here, you know, and you know that they're at all the tendon attachments, well, this is why Lyme can be so easily confused with fibromyalgia. So the biofilm I talked about, it's a gelatinous coating around the Borrelia, and they live within these biofilms. And in vitro, they make them 1,000 times more resistant to antibiotic therapies. And this has been shown not only in vitro, but also in actual skin biopsy specimens. This is what happens over time if you put Borrelia in culture. As you go from the slides from A, B, C down, you see they start to pair up, then become a network, and finally become a thick mat of spirochetes. Here's a 3D picture of what they look like, with pits and valleys and mountainous type things. And this is an internal circulation to get the nutrients in and out. But the thing about a biofilm is that it's a dynamic process. Organisms enter and leave the colony. So it's thought that why some patients need long-term antibiotics if biofilms are present is because you have to have something there treatment-wise while the Borrelia start coming out of this biofilm to get them killed off. Another thing I want to talk about is it had been said that you need to have a tick attached for a day, even 36 hours before you get transmission of Lyme disease. Well, those studies are based on studies with rabbits, and rabbits don't get Lyme disease the way humans do. But actually, Willi Bergdorfer told me years ago that a certain percentage of his ticks, he actually quoted 5 to 10%, have an infection in the salivary gland. So as soon as the tick bites, has a risk of transmitting Lyme disease. Well, sure enough, the papers published in 2011 which showed that many cases of Lyme being transmitted with only a 5-hour or less tick attachment time. Now, if a tick is engorged and it's an infected tick and it's removed improperly, even if it's not really engorged, if it's removed improperly and it's broken open, well, whatever germs are in that tick get rubbed into the wound and it can actually cause an infection. So there's so many different reasons why, and some people don't know it's a tick, they scratch it off. So many different reasons why you don't have to have 36 hours for Lyme to be transmitted. So don't say, oh, it was only on a few hours, don't worry, you don't have any problem. I, as a clinician, have seen 5-hour attachments cause Lyme disease and even less. And here it's been published. Talk about some diagnosis. Nice pictures, hey? We always say Lyme's a clinical diagnosis, because the testing is not 100% accurate. A positive test will support the diagnosis, but you can't say someone does not have Lyme because the test did not show it, because the tests are not that sensitive. So how do you make a clinical diagnosis? You go through, have they possibly been exposed? Do they have a history consistent with the illness? Are there signs and symptoms that are consistent with Lyme disease? Results of specific tests for Lyme. And sometimes, you know, Lyme is a diagnosis of exclusion, so you have to look at tests for other things to rule them out. Now, you talk about exposure. A study by Texas, only 17% of the patients with Lyme disease recalled a tick bite, and only 36% of them had a recognizable rash. Now, Texas may be different than the East Coast, but still, in our experience, less than half the people with real Lyme disease ever saw a rash. So we'll talk about the history. It's a process of pattern recognition. So think about someone who's been well, and suddenly they get this strange multi-system illness for no apparent reason. So what about potential exposure? What's their occupation? Are they landscapers? Are they people who work out in the brush? Do they go hiking and hunting and that kind of thing? Are they exposed? Do they travel to areas that are tick exposed? How about their pets? Do their dogs and cats come in home with ticks on them? Well, that means there are ticks in their environment. How about other family members or even their pets having Lyme disease? These are all kind of risk factors. And in my personal experience, people who work around horses are very high risk for Lyme disease. And it's almost a joke, like if they commit this strange, unexplained illness and they work around horses, it's Lyme until proven otherwise. Next thing is, how did the symptoms evolve over time? It begins with a non-specific presentation, like someone has a virus, aches and pains, flus, maybe they think you have a sinus infection because of the head pain. But over time, these symptoms not only persist, but new ones start to appear. And over time, these new symptoms become focused on different organ systems. So you start to get musculoskeletal, neurologic, cardiac, and so forth. Different things start to get involved. And this can progress to the whole body multi-system illness. And the other thing is patterns emerge. The symptoms don't constantly happen day to day. They wax and wane. And I have all my patients keep a daily diary of their symptoms. And you'll find that this 4-week cycle actually repeats itself. So not only do the symptoms wax and wane over this cycle, but the location and type of symptoms change. For example, they can have bad knees for a few weeks. Then they seem to get better. And then the shoulders hurt. Then they get better. Then they get terrible tingles. And it gets better. Then they have headaches that don't go away. Then that seems to go away. And then their knees come back. It's because the Borrelia over time changed their genetic expression. And you can actually find different serotypes in the same patient. Dr. Packner did a study where he injected Borrelia into a mouse, let it sit for a while and cook, I guess. And then after the study was done, he analyzed the Borrelia in the brain and those in the peripheral blood. And the strain in the brain was different than what was in the peripheral blood. The Borrelia learned to adapt to the host environment, and it changed strain in the central nervous system. So that's why you see things moving around, and that's one of the clues of Lyme disease. Now, if someone has a bad knee and nothing else, they're completely fine, they have a bad knee, that's usually not Lyme disease. But if someone has knee problems and neurologic problems, peripherally, autonomic things, the brain fog, the confusion, the word search, fatigue, temperature patterns, you start to think of a multi-system illness that's moving around. The rash of erythema migrans only appears in 50% or less. And it may be hidden. It could be in your scalp or in your back or in your groin, under your armpit. You may not even see it. Actually, the most common rash of Lyme is really not a rash at all. It's a little bump like a mosquito bite that persists for a period of time. Now, if you do get an EM rash, it may not look like you see in pictures because it follows skin planes. So if it's on your side, it might be oval. If it's by the axilla, it might have triangular shape. It all depends on where it's located. But they are painless, and they're raised, they're warm, they rarely itch, and they even go away without treatment. Now, it had been said that the most common physical finding in a Lyme patient is a normal exam. I absolutely disagree with that. There are always signs, but you really have to dig and look. So let's go through the list. If you have them keep a daily diary of their temperature ranges, you find that most of them are low in the morning and above normal in the mid-afternoon. I'm talking about 99.2 to 99.6. They may not even know it. Check them for orthostatic hypotension. That's very common because of autonomic dysfunction, hormonal imbalance, and so forth. The basic appearance. How well do they speak? Are they thinking clearly? They say, oh, I'm fine, but they can't remember their mother's name. Look for rashes that they may not have seen. Look on their back and so forth. Look for subtle things. The conjunctival injection, the red crescents in the tonsils. Look for what looks like a sore throat that they don't even know is there, but you can see this very, very commonly in Lyme, and you can actually follow that as they get better. Thrush. As I mentioned briefly, Lyme is immunosuppressive. It attacks and inhibits B cells, T cells, and killer cells. And I've had a number of patients come to me who've never had antibiotics, who had an yeast overgrowth because of the immune suppression. So look for that. It's very important to do a very thorough neurological exam. As Lyme progresses, it's predominantly a disease of the nervous system. So you have to do all the cranial nerves, including a gag reflex, corneal reflexes, check the extraocular muscles. Learn to read deep tendon reflexes. They could be absent, they could be delayed, and you start to think of, well, maybe hypothyroidism is there. If they're very brisk without clonus, you have to think maybe there's a magnesium deficiency. If there is clonus, you have to worry about motor neurons. Now, at every single visit with every single patient, every single accessible joint should be examined. And you really need to do this. Number one, you're going to find things you didn't think were there. Number two, as clinicians, you're going to learn how to do a good joint exam. You're going to find subtle things like a little thickening in those synovia. I know this has a little bit of warmth, but you have to do it every single time in every patient. You can write in the chart, oh, a slight synovial thickening on the left knee that wasn't there before, or there's thickening and swelling that's now only thickening and then it's finally going away. But look at every joint and you'll see it. You really will. A lot of Lyme patients get involvement of the neck. They get this stiff neck and they're doing what I call the Lyme shrug. They're sitting in your office going like this, cracking their neck all the time. Now, is that specific for Lyme? No, but that's part of this multi-system thing. You know, you want to also make sure you're ruling out other diseases, so check for hepatosplenomegaly, check their thyroid carefully, listen to the heart and lungs. Now, many, many patients with Lyme, very many patients get costochondritis. Lyme attacks cartilage, and it loves the chest cartilage for whatever reason. So many of my patients in and out of the ER thinking they've had heart attacks when it's just a sore rib, so check for that. Laboratory. Very difficult to do a good lab test for Borrelia. The Borrelia come in many different variants. We have a number of different species of Borrelia, and within the species Borrelia burgdorferi, in America alone, there are 200 strains that we know of. Some people even think 300 strains. They change over time, and they adapt to different environments, like I told you about the spirochete in the brain versus in the body of the mouse. So we have this, the Borrelia in the wild are very adaptable and very changeable. They're very, very different from what we use as laboratory strains when you develop our blood tests. The thing is, nearly every commercial blood test, from LabCorp, from Quest, from Europe, they are based on laboratory strain called B31. Lab B31, that strain came from a tick. It never tasted human blood. Yet every blood test and all the studies you read about, they use the strain B31. Now you can go to a medical supplier and buy a vial of living B31, and they don't look like the pictures I've shown you. They're different spirochetes. So this is one germ, not from a human, taken at one point in time. How can this possibly reflect all cases of Lyme from all different geographic areas in this country, from patients who may travel overseas? It doesn't make any sense at all. So what's the result? A commercial ELISA has an average sensitivity of 49%. This is published. I'll show you the reference. The C6 assay was supposed to be wonderful. It's just as bad as the ELISA. Now, if you read the studies, they say the C6 is 100%. No, it's 100% comparable to the ELISA, not 100% sensitive in picking up Lyme disease. So read carefully the literature. So the C6 is just as insensitive as the ELISA, and the clinical impression for many of my colleagues, and me too, is that the longer someone is ill with Lyme, the less likely their serologies will show. Between immune suppression, immune complex formation, and so forth, you lose this seropositivity. A Western blot is probably no better than an ELISA, maybe a little bit better, unless you go to a reference lab where the sensitivity is up to 80%. Another problem, you can get false positive IgM serologies in the presence of DNA viruses like Epstein-Barr, Parvo, and so forth. Now, it's also been said that to prove you have neuroborreliosis, Lyme of the central nervous system, you have to have a positive spinal tap. Positive meaning antibodies present in the spinal fluid higher than in the peripheral blood. Well, studies were done at Stony Brook in New York where they found only 9% of people with documented Lyme of the central nervous system had a positive Lyme serology in the spinal fluid. 9%. In other words, 91% false negative. So think about it. Borrelia are introduced into the bloodstream right after the tick bite. And I hope you have blood in your brain. So the Borrelia will get to the brain. They very rapidly transit through the endothelial cells and through the basement membrane into all the different tissues. And studies in animals have shown transmission within hours of the bite. In humans, documented within a few days of the bite, you get it in the central nervous system. So to say that you have to have a positive spinal tap serology to prove Lyme is in the nervous system makes absolutely no sense at all. So don't believe it. Now, and final thing is, serology is an antibody test. It shows past exposure, not current disease activity. Here's a reference showing the average sensitivity of ELISA is 49%. So in other words, it's a coin toss. Is it Lyme? I don't know. We'll toss a coin. Now, Western blot is better because instead of quantitative, it's qualitative. And you can look at what are called the bands. Now, the way you interpret a Western blot is that there are some bands, some antibody reactivities that are specific for Lyme Borrelia, some that are non-specific for other Borrelia or even spirochetes, and some that are just every bacteria has. So the bands that you see here, the 23-25 complex, 31, 34, 39, and the 83-93, these are the ones that are found in Borrelia specifically. So really, you want to have at least one of these bands, and two would be better to be positive. If the only positive band is band 31, that's a different situation because band 31 can also be from some viruses. So the lab called IGeneX, they have a booth here, they will do what's called an epitope test to see if that 31 is from Borrelia or from a virus. Now, you can have a late positive IgM, sometimes a false positive, but often they're not, because again, the Borrelia regenerate every 4 weeks, you get new IgM responses. So don't ignore late IgM, but just be aware that there can be some false positives. The reason why we say we don't follow the CDC Western blot is the CDC criteria don't use bands 31 and 34. That was removed because of vaccine studies back in the 90s. And so the two most specific bands for Borrelia are not even on that Western blot list. And to say you have to have 5 out of 10 doesn't follow statistics. So don't use the CDC criteria. Now, as good as a Western blot is, this is an actual Western blot. Sensitivity in commercial kits, maybe 50-50. A reference lab, such as IGeneX, Stony Brook, maybe 80%. But the reading is subjective. So these are what we call the bands. See 31, 34. This strip is a reference strip. The first lane is a negative control. So over here, let's say this band is very dense. Obviously, there's Lyme there. Here's another band. This one, it's kind of faint. This one down here is faint. What about these things up here? How do you know when do you call a Western blot positive? You know, and what about this band? Is that positive? I don't know. A subtle change in the temperature. These are put in a water bath with chemicals in it. Change the temperature 1 or 2 degrees, change the composition, and the bands appear or disappear. You can take the same patient's blood to 3 different labs for Western blots and get 3 different banding patterns because it's kind of hard to interpret which is which. But the thing that some labs do, IGeneX, one of them, is they give you a reading. They say the band is plus or minus, or 1 plus, 2 plus, 3 plus, so you can actually make your own interpretation. So yes, a Western blot is much better than a serology, and I don't even do an ELISA anymore. I only do Western blots, but be aware that it's still a subjective interpretation. You can do DNA detection, such as PCR, but they're not sensitive, 20 to 30% at most, even if you do several over time. There are inhibitors of PCR in the blood, which makes it very difficult. Also, it's a trade-off of sensitivity and specificity. If a broadly sensitive PCR, you'll pick up germs beside the Borrelia you're looking for. If you focus on one strain of Borrelia out of the 200, you're going to miss a lot. Now, PCRs are often dismissed as being contaminated. I don't believe it because good labs have good techniques, but that's what the critics like to say. Another thing is if you have a positive PCR, is that current infection, is that leftover DNA from an old infection? I believe that it's a new infection because DNA doesn't hang around. We have DNA aces in our bloodstream that take away foreign DNA. But then they say, well, how can you have DNA from mummies show up? Well, the mummy is not alive, doesn't have active DNA aces. Nevertheless, the critics say PCRs are not something you should use, and that's why insurance and CDC don't use them for criteria. You can detect antigens of Borrelia, in fact, whole Borrelia, as I showed you from NIH, in the urine, but we don't really know whether all the strains that cause Lyme are picked up by this. The spillage of the antigens, if you do it every single day and follow a person over time, some days they spill, some days they don't. And sensitivity overall is about the same as PCR, about 30%. Also, it's not accepted as proof for CDC or insurance. T-cell assays, they see whether your T-cells react to the stimulation by a Borrelia in vitro. The number of different methods being used, we don't know what strains they pick up. Some people who've had experience with this say, well, you get false positives, false negatives, so it's not that popular in America. It's used more in Europe, but they have more experience with it. Again, the CDC and insurance companies don't accept that. You can do culturing nowadays for Borrelia. It is a very big advantage because you directly can detect if someone has living active Lyme right then and there. So not only can you use it for diagnosis, but you can use it post-treatment if someone has a relapse or symptoms just never went away. And it is accepted by CDC and insurance. The disadvantage, it's very expensive. It's only the peripheral blood. You can't do urine or anything else. You need 4 red top tubes, which means a lot of kids just can't give up that much blood. Also, culturing, as I said, grows very slowly. About 1/3 of them can be reported within the first week, but the rest of them take anywhere from 8 to 16 weeks to show positive. Also, if someone's been exposed to antibiotics, you can't do the test because that'll wipe out the positive culture. They have to be off antibiotics for 4 to 6 weeks, and you may need more than one set. But the beauty of the culture is that it really is very accurate. In the published study, the sensitivity was up to 94%, which is much better than an ELISA. And also, you're looking at the germ. This is what I learned from McDonald back in the 1980s. You actually see it with your own eyes. And that picture of spirochetes I showed you early on came from this kind of a culture. The culture test was criticized, saying, oh, there must be some false positives, some contamination, but there's actually never been a false positive in 2 to 3 years of use of this. And every single culture is run with a positive and negative control, and they've never found contamination. Another thing you can do is you could complement split products. There's a C3A and a C4A. C4A is more commonly found elevated in active Lyme. And with treatment, the C4A, if treatment is successful, will start to come down and go back to normal toward the end of treatment. So you can actually it can actually help you to follow your patients clinically. So my recommendation is if you see the patient initially, draw a Western blot, do the C4A. I really don't recommend you do an ELISA unless the patient's insurance requires it. If the patient is seronegative but the Lyme is still suspected, then definitely do a culture. It's much more reasonable to do at that point. You can also consider doing urine and PCR for antigen, but that can be helpful sometimes, but it's still insensitive. Follow the progress with the C4A. And anyone who has persistent symptoms post-treatment, either relapsing or just not getting better, repeat the whole thing. Do the culture, do the Western blot, and C4A. But again, it's not a laboratory diagnosis, it's a clinical one. So how do we figure this out? How do we do it? Ta-da, we have a diagnostic scheme. This was first proposed at the Lyme Disease Association conference back in 1991, I believe, in Orlando. And it's a weighted point system. It's pretty obvious to see the interpretation. 7 points or more, Lyme is highly likely. 4 below, it's unlikely. And in between is in between. This has been validated in 2 different studies totaling 150 patients and 50 controls, and was found to be accurate, very, very accurate. So it's in your book, so you don't have to worry about taking quick notes. But I recommend you do it. It's also great for documentation for insurance, for your chart, so forth and so on. Treatment. You thought diagnosis is tough. Here we go. Why is it hard to kill these stupid germs? Stupid germs, that's a medical term of the morning. All right, first of all, they grow slow. They have latent periods where they don't grow. The slower the growth, the longer it takes to kill them off. Antibiotics don't kill bacteria when they're not actively growing. Now, in humans, it's a distinct 4-week cycle. Remember, it's a Borrelia. It comes from relapsing fever. That's why they call it relapsing fever. You have weeks of fine and weeks of fever. And in humans, it's a 4-week cycle with Lyme. So if someone has waxing and waning symptoms, and they keep a daily diary, and look at that. Every second week of the month, for example, is when it happens. Women who are hormonally active, if it overlaps with their menstrual cycle, it's even more exaggerated. So if you see a 4-week cycle, that's a sign that the infection is still active. And it's very important you keep note of this, because it's going to help you with the diagnosis, it's going to help you with following them during treatment, and help you figure out when to stop treatment, and help figure out if the things are gone or if they're coming back and so forth. So the 4-week cycle is an important thing to note. Now, another problem, as I mentioned, there are 3 different morphologic forms. There's the spiral form, which has a cell wall. The cell wall deficient L form doesn't have a cell wall, so cell wall antibiotics like penicillins don't work for that form. Then there's the cystic form that doesn't have surface antigens, the immune system doesn't attack it, and it's protected in a cyst. So you have to bust the cyst to get them open, and then use an antibiotic to kill them. Now, another thing is, Borrelia can live inside cells and live there and not be killed by the vacuoles. And they can live in the cells and burst out of the cells and keep the infection going. But they also can live in the body fluids. So they can live in the cells, they can live outside the cells, they can live in the body fluids like the spinal fluid, the blood and the urine and so forth, but they also can live deep in the tendons like I showed you before. So you have to have antibiotic regimens that go to all these different areas. Biofilm is a possibility. And the immune suppression, as I mentioned, it affects all the arms of our immune system, the B cells, the T cells, and the killer cells. They also interfere with the signaling of these cells. So it really does take a toll on the immune system. So in choosing antibiotics, you have to optimize the whole process. We have to often use combinations of antibiotics in the more sick patients because of all these different conditions. You have to reach the hidden spirochetes, you have to go to the different areas, you have to get into the different parts of the body. The doses also have to be maximized to kill the Borrelia, to get the antibiotic into these protective niches, into the ligaments, into the central nervous system. And it's illogical to arbitrarily limit the duration of treatment. You say, cancer, I gave you 10 days, you're cured. That's not true for any other illness, be it Lyme disease, cancer, urinary tract infections, pneumonia, anything. You follow the patients clinically, especially if they're very sick and immune suppressed. So when you're choosing an antibiotic, they have to have extra and intracellular sites of action. For example, penicillin, cephalosporins work extracellularly. It's hard for me to say that in the morning. Macrolides, tetracyclines, they are the intracellulars. Antibiotics have to work in the body fluids as well as the tissues. Again, the penicillin, cephalosporins work in the fluids. They don't go into the cells and the tissues well, but the macrolides do. The regimen should cover the 3 different morphologic forms. So for example, a cell wall drug for the spiral form, a ribosomal agent like a tetracycline or one of the mycins for the cell wall deficient form, and then an azole like metronidazole, which is flagelltinidazole for the cystic form, because that will open the cyst and allow the antibiotic to then work. And again, this is why often we use antibiotic combinations. It's all common sense and logic. Now, dosing, I'll tell you why it's interesting. This is what's called time-killing curves. For a cell wall drug to work, like a cephalosporin or penicillin, you have to have sustained bactericidal levels for 36 hours to kill the Borrelia. It's like having a big, thick cake of soap you want to dissolve in running water. It takes time to dissolve the thing. So if you have an antibiotic that has a short half-life, or if you don't dose it frequently enough, and the trough level falls below the MBC and MIC, you're going to have the spirochetes recover. You're not going to get rid of the infection. So you really want to measure blood levels, and I'll show you a slide on this in a second, and make sure that the trough levels are above 3. Now, for tetracycline to work, it's just the opposite. You need a spike. So, for example, you're using doxycycline, and you're using, say, 400 milligrams a day, which is a recommended dose for adults. You don't use 100 milligrams 4 times a day. Try and use 200 milligrams twice. If you're doing tetracyclines like Doxy IV, you don't do 200 milligrams twice. You do 400 milligrams once a day. You want a big spike. It's also why IV Doxy works better than oral. Even though the blood levels may average out to be similar, you want the spike. And again, the goal is a peak of over 13 for any of these drugs and a trough over 3. Now, the macrolides, they concentrate in tissues, so you can't draw blood levels. They're not available, and it doesn't make any sense. Now, I did a study years ago, back in the 80s, where we took amoxicillin at the then recommended dose, 500 milligrams 3 times a day, which is still in some textbooks. It drives me crazy. Doubled the dose to 3,000 milligrams a day. We added probenecid to that to make the longer half-life to get the trough levels up. And then I checked blood levels. And I found matching patients for age, for gender, and for body weight, and same brand of amoxicillin, there's a 100-fold difference comparing the highs to the lows. So not everybody absorbs it well, not everybody excretes it at the same rate. With doxycycline, did a study on patients who had disseminated Lyme, not the chronic, hard-to-treat Lyme, but people who had Lyme for a few months. 300 milligrams a day did not cure any of them, not a single person. Doxycycline at low dose, and 300 milligrams in adults is considered low dose, is bacteriostatic, not bactericidal. You have to go at least 400 milligrams to get to that level. Some patients need 600 milligrams. Again, doing blood level studies, matching the patients, a 10-fold variability in doxycycline levels were seen, and this was reported at one of the Lyme meetings. So anytime you have a patient on a drug like amoxicillin, Ceftin, which is cefuroxime, and doxycycline, you can get LabCorp and Quest to do blood levels, and you should do it, see what it looks like. So the recommended dose for adults, amoxicillin is 1 gram every 8 hours, pediatric 50 per kilogram, and you add probenecid 500 every 8, and then you check the blood levels, and you have to raise it up, you do it. Ceftin, cefuroxime, I begin with 1,000 Q12 in adults. Some people don't have the nerve to do this, so they start at 500, but then again, check the levels. You may need to add probenecid. Cefdinir used to be called Omniceft, now it's only generic. The normal dose for example, respiratory infections, 300 milligrams every 12. In Lyme, I found you really need 600 milligrams. You may also need to add probenecid. Let me tell you a quick story. I had a patient who knows of Lyme, had it before, had developed an EM rash after a known tick exposure, couldn't get to my office right away, so finally came in. By that time, the rash had faded, but she was having some systemic symptoms. So I put her on Ceftin, cefuroxime, 1,000 milligrams every 12 hours, which again is double the dose you give for sinus infections. She wasn't really getting that better. I saw her a few weeks later. She was still kind of sick, did a few weeks later, still not good. Did a blood level. She wasn't absorbing it. Her peak level was less than 1. I put her on doxycycline, 400 milligrams, got a good blood level, and within 6 weeks, she was completely well. Now, if I went back and didn't do that, I'd say, oh, she's treatment resistant, the drug doesn't work, maybe it's not Lyme, maybe it's post-Lyme, maybe she's faking it, maybe she's crazy, I don't know what it is, it's lupus, she's got all this stuff. Did a simple blood level test. It was the drug that wasn't working. So I always insist on this. If you can do a blood level test with the medicine they're on, you should do it. It definitely is important. It makes a huge difference. All right. You can't use tetracycline, as you know, in children in pregnancy, and it can be difficult to tolerate. But again, doxycycline, we go 400 milligrams a day is what we start with, and many patients end up on 600 if they can tolerate it. When it comes to the erythromycin family, the mycins, there's a lot of talk about, oh, maybe there's cardiac toxicity. Well, it's simple. Do a cardiogram on the patient beforehand, measure the QT interval, correct it for their RR interval, and see if they have QT prolongation makes these drugs dangerous. If you're really insecure, once they're on the medication, repeat the cardiogram and see if anything changed. And don't be afraid of them. They work very well. For IV medications, we use the standard doses, what's been published. You can measure blood levels of doxycycline. If you have patients on Vanco, which is a second, third line drug, you can measure those. You can't measure levels of Rocephin clinically. Now, the doses may have to be modified, and I'll show you that in a second. Sometimes when patients have HERXHEIMER reactions, you have to cut back the dose because it gets strong. Sometimes they get leukopenia and elevated liver enzymes in the beginning, and it's not a drug side effect often. It's often a side effect of the HERXHEIMER reaction. And you may have to back off or maybe just skip a few days. We call that pulse therapy, and I'll share what that means in a second. Now, again, bacteria are killed during the growth phase. Borrelia growth is not steady, it has this 4-week cycle to it. So you have to have enough treatment in an active infection to bracket one whole 4-week cycle. So the minimum treatment, for someone who, let's say, just got a bite and just starting to maybe get a rash, minimum is 4 weeks. If they have any symptoms at all, in my opinion anyway, you have to do 6 weeks. Otherwise, you're going to see treatment failures. Now, if you just look at doubling time and empirically, mathematically calculate it, it says 26 weeks of treatment is needed to kill Lyme disease. Now, I don't know if that's really true, but just to emphasize the point, it's more like treating tuberculosis as it is like treating strep. So I did study this using the higher dose of amoxicillin and adaprobenecid. I took patients with disseminated Lyme and tabulated the success rate. I gave them a month of treatment, 6 weeks, then 2 months, 3 months, 4 months, 5 months, 6 months. And I found that at 1 month of treatment, if I stopped there, only 17% got well and stayed well after 3 months of follow-up, which is my definition of success. I'm talking about minor symptoms as well as the major symptoms according to Yale. However, if you increase that, there's a linear increase in sensitivity, or success, I should say. By the time you got to 4 months of treatment in males and 6 months in females, it plateaued at about 67%. So again, these are patients who had disseminated Lyme, not the chronic Lyme where the people have been sick for years and years, but people who had less than 1 year of illness but who had disseminated Lyme. It really needed that much treatment to get them well and stay well. With IV, we did a culture study. It took 26 patients, gave them ceftriaxone, Rocephin, gave it to them for 14 days, and some got 2 grams a day, which is a normal dose. Some got 4 grams a day, which is double dose. Now, we cultured them at the beginning of treatment. They were culture positive. At the end of treatment, they were all culture negative. But you know what? Every single patient, all 26, after a period of time, they start to get symptoms back, usually 3 or 4 weeks later. When we recultured them at that point, 100% of them were culture positive. So not only did all of the symptoms come back in every patient, but everyone had a positive culture. So that means a 100% failure rate of 2 weeks of ceftriaxone IV. So again, I recommend at least 4 and preferably 6 weeks of an IV treatment to bracket this magic 4-week cycle. Now, if you're done with the IV at that point, either because you don't want to go longer, the patient doesn't, insurance doesn't allow it, well, don't stop treatment then. Remember, 4 to 6 months is really what you need on the average. So you can go from the IV to an oral or an IM regimen, which I'll show you in a sec, and that can help you to get to that endpoint. Now, is it reasonable to do long-term treatment? We've had a lot of clinical impression that this works, and finally a study was published, and they found that prolonged IV antibiotic therapy is associated with improved cognition, fatigue, myalgias in patients. Now, these are the so-called minor symptoms that had been dismissed as the patient's just being crazy or malingerers. Well, they actually can get better with long treatment. But these people are treated for 25 to 52 weeks on IV. Now, years ago, before we had insurance restrictions, some of my patients were treated this long, if not even longer, on IV, and they really did well. So the flip side is, right, what about side effects? Well, another published study, I don't have the slide up for this, but it showed that it is safe if done properly and with someone with experience. Now, who gets IV? Who gets orals? Who gets shots? Who does what? Well, a study was published from Columbia University by Dr. Fallon. Chronic Lyme patients. Placebos did not work, no surprise. Oral antibiotics helped in some subjective symptoms, but nothing you could measure in terms of neurologic testing. IM penicillin, the bicillin, the benzathine penicillin, really did pretty well, much better than the orals, but the IV was mostly effective. Now, I went back through my first 633 patients to see who needed IV versus who didn't. And these are the things that came out statistically. If someone has a reactive spinal fluid with white cells and protein elevation, by and large, somewhere along the line, they're going to need IV treatment. If they have the rheumatoid form of Lyme, only 5% get this, with a high SED rate synovitis from the Lyme itself, they end up needing the IV. They're sick for more than a year. Now, the definition of chronic Lyme is vague. No one has a unified definition. ILADS is trying to work on one. My own definition is if someone's been sick for a year or more, I call that chronic Lyme. Why is that? Well, clinically, I see something happens after a year. Biologically, that's when you start to see the immune suppression. Now, it's a year in my mind, whether they've had treatment or not. If they're still sick after a year or sick and haven't had treatment yet, or not enough treatment, they're in the chronic Lyme phase. So then when I looked at the patients who were sick for more than a year, by and large, they were more likely to need IV to get over this. Age over 60, people in the first trimester with disseminated acute illness, of course you want to do IV. Acute carditis, that's pretty much standard. Obviously, someone with an immune deficiency, someone who's been given immune suppressor drugs during the Lyme, either by mistake or whatever, they end up needing IV, and that's actually been published. And obviously, if someone can't tolerate orals, IV is the way to go. Now, there are two different kinds of IV schedules I want you to learn about. The standard therapy, you give an IV once a day for 7 days a week, usually for 4 to 6 weeks, sometimes longer. So if you're using ceftriaxone, Rocephin, it's 2 grams a day, once a day, and that's it. The number of patients who failed this, and studies were done in Europe where they actually biopsied the patients post-treatment and found they still had spirochetes. They say, how can they survive a month of Rocephin? So they decided we need to double the dose. How do you double the dose for months at a time and not get the patient sick? Well, it takes, as I mentioned, 36 hours to kill Borrelia. Once they've been hit, it takes a whole month for them to regenerate. That's that 4-week cycle. So they said, why don't we just give them a double dose for 3 days and stop? Then at the end of the week, we'll do it again. 3 days and stop. So they gave pulse dose, they actually gave 2 days, I gave 3. So pulse therapy is where you can give a higher dose 3 days in a row. It can't be Monday, Wednesday, Friday, it's got to be 3 days in a row each week. So for example, using Rocephin again, you give 2 grams BID, so you have nice trough levels, 3 days on and 4 days off. Now the beauty of this, a lot of things, you don't have to have a long PICC line, which is the #1 source of side effects in Lyme IV treatment. You can do a simple heparin lock. It'll last 3 days. The patient takes the lock out. They can take a bath. They can swim. They can do what they want 4 days in a week. So it makes life so much easier for them and much, much safer. It also allows you to give a medication like a second-line drug. For example, it's been shown that in people who fail Rocephin therapy, you can treat them with vancomycin. Now, that's kind of a scary drug, and you don't like to give that for a long time. But if you give it 2 or 3 days a week, and the rest of the week you don't give it, I'll knock on wood when I say this, because I've treated many, many patients with vancomycin without any side effects related to vancomycin at all. Also, it's a very good way to manage a HERXHEIMER reaction. If someone starts to get really sick with Lyme, you can actually back off for a second. Let me show you how that works. Now, there's some side effects, there's some exceptions. The azole drugs, for example, Flagyl, the time killing curve is not a 36-hour, it's 14 days. So if they can tolerate 14 days of a drug like Flagyl or tinidazole, you give 14 days on, and I usually give 14 on, 14 off. Some patients can't get to 14, so we'll do 10 days on and then give them the break. Next cycle, try to do 14 on, 14 off. Azithromycin has a very long half-life, as you know, so you really can't pulse it, but you can give it Monday through Friday, have the patient take the weekend off and give you a break from phone calls. Bicillin is a long-acting penicillin that, by definition, you can't pulse it. It doesn't, no such thing. But again, this is for Borrelia. It doesn't work this way for co-infections like Babesia. Some more examples. Clafuran instead of Rocephin, Primaxin, ceftaroline, vancomycin, all these have been used in Lyme with success. IV Doxy works beautifully as a 400 milligram once-a-day dose. Again, you got to check the levels. IV azithromycin works much better than oral. I've really had very poor luck with oral azithromycin. I usually have to go to 1,000 to 1,200 milligrams a day to get it to work orally, which is hard to tolerate and hard to afford, but IV does work well. And again, with any of these regimens, you can add an azole to get to the cystic form. So let's talk about Herxheimer's. Spirochetes slowly metabolize, they slowly give off toxins. As you kill them, they burst, and these toxins come out all at once. So this initiates a cytokine cascade. The symptoms will flare, old symptoms come back, new ones appear. Sometimes you think, is this a drug side effect? Is it an allergic reaction? Begins a few days into treatment, may last a few days or even longer. It's going to recur every 4 weeks. As the spirochetes get into the growth phase, they get to be killed off, they get to lyse, they get to have another Herxheimer reaction. Again, you can see low white count, elevated liver enzymes. How do you figure this out? The patients who are more sick are more likely to get a Herxheimer. Those who have been sick for a longer period of time, and those at the time of puberty. Something about young kids, especially young girls, the hormones or whatever, we don't know, but they're much more prone to severe Herxheimer reactions, so go carefully with the young kids. Now, if someone's a very severe neurologic condition, you don't want them to get set back. Chemically sensitive individuals, especially here with all the mold around. Someone's very elderly, you want to, frail patients, you want to be careful. But again, this is for the chronic Lyme. In early Lyme, the Herxheimer reactions are well tolerated, and you just push through it. Now, how do you manage it? Now, a strong Herxheimer might scare you and scare the patient. I don't want to do this. Take out this IV. I'm going home. I don't want to do this. But the thing is, if you say, we'll start with a half a dose, even like 500 milligrams of Rocephin, not 2,000. Well, the thing is that Borrelia can very rapidly develop drug resistance. So if you start too low of a dose, you're going to kill the weak germs, leave the strong ones behind. You don't want to do that. So on the one hand, if you want to treat strong, which is a great idea, then you get a Herxheimer and you get scared. If you treat gently, you get drug resistance and a hard patient to cure. So what I found is this is an ideal thing to do with pulse therapy. Get someone on treatment. After 3 or 4 days, as I say, I'm starting to feel bad, so I'm going to completely stop. Let everything settle down, let the rest of the week go by, then do it again. And usually they can get through it that way. So I really would recommend, rather than cutting the dose, you just interrupt it and then go back on again. Some patients actually develop hives, and that's scary. Are they now allergic to the drug? Well, I did a study with my local allergist, and we had him objectively allergy test these patients with the drug that caused this reaction. And he published this. 87% of the time was just part of the Herxheimer. They weren't able to go back on the drug. So what we would do in that case is he would let the whole reaction settle down over several weeks. We give them a very tiny testing dose in either emergency room or in the allergist's office. If that's tolerated, then the next dose would be a normal sized dose, but given slowly and monitored. And if that's okay, then they go back through the whole treatment. So how do you manage the IV regimen? As I said, the 4-week Lyme cycle is so important. In my mind, you want to bracket the whole cycle. So 6 weeks, to me, is minimal for IV therapy. Now, if they've had a really strong Herxheimer in the beginning, and at week number 4, Herxheimer is also very strong, you know there's a lot of Lyme still in them, you want to keep going. So you can decide to extend the IV treatment if it's covered in 4-week intervals. So 6 weeks to me is minimum. The next decision point is 10 weeks and 14 weeks and so forth. However, once you get to a clear benefit where the 4-week cycles are minimal, you say, all right, you can stop the IV. We're going to go in the follow-up, either oral or IM, to get you to that 4-6 month point or more. People worry about gallstones and so forth from Rocephin because it is excretes with the bile. Simple ursodiol, which is Actigol, is used to dissolve gallstones. You can use it prophylactically. We found good success with this. It's not published, but it's just kind of common sense. We recommend in the first month, every week you check blood counts, liver enzymes, and less often as if you see they're stable. Bicillin, benzathine penicillin, that can be useful in Lyme disease. Initially, it was published to use it once a week, 1.2 million once a week. It didn't really work that well. We find in adults you need at least 3 times a week, sometimes 4. And in some people, this is as good, if not even better than the IV. And it's great, especially in pregnancy, because it's safe and tolerated in pregnancy. You don't have to worry about the wife or the young lady getting morning sickness and throwing up pills, not the hassles of an IV. Now, because it's a cell wall drug, you may want to add a macrolide, for example, Biaxin to that. And you also can add an azole. You even can add probenecid if you want to give someone bicillin 2 times a week because of the shots being painful. The probenecid every day might help that. Oral regimens, cefuroxime, which is Ceftin. Again, the recommended dose for skin and sinus infection, 500 milligrams every 12. In Lyme, if you check levels, you're going to find most of your patients need 1,000 every 12. You may need to add probenecid. Amoxicillin, as I mentioned, is 1,000 Q8 plus probenecid. Doxycycline, don't get stuck on 200 milligrams a day. You're going to kill the weak germs and leave the strong ones behind, kill the superficial ones and leave the deep ones in there. Go the full 400 milligrams. Pregnancy, as I mentioned, tick bites at a high risk, you want to treat that. If the Lyme is active, you use IV or IM, plus added azithromycin, which is safe. Treat for the whole duration of pregnancy. Test the cord blood of the baby. You can do a culture and PCR on that. And this is not often done. It's not done often enough at all. And check the placenta. Look for inclusion bodies, because inclusion bodies have a 50% correlation with development of autism. So a good pathologist will know how to look for that. We did a study years ago with only 4 patients who had Lyme during pregnancy with EM, known Lyme symptoms, refused treatment because they don't want to get antibiotics while pregnant. When the baby was delivered, we checked their breast milk. 4 out of 4 were positive for Borrelia, 2 by PCR and 2 by culture. Now, what does that mean? Does it mean someone who's had Lyme during pregnancy should not breastfeed? I don't know. It's risk versus benefit. You know, I'm sure a mother would be very upset if she gave her baby Lyme because of this. But on the other hand, breastfeeding is good for the baby. So I don't have an answer for you, but just to be aware that this might be a risky thing, you need to have a conversation with the patient. And obviously, follow the children very carefully. And in pediatrics, the dosing is based on body weight. Kids, the drugs have a shorter half-life, so make sure that if you can't check blood levels because you don't want to take so many blood tests, make sure you decrease the intervals, add some probenecid if it's a cell wall drug. Measure the cardiogram, maybe their first lifetime cardiogram, but do it in a kid if you're going to give a macrolide drug. You don't want to have someone have heart issues. And kids are poor historians. Be proactive. Ask them what's going on. Have them make pictures, whatever kids will do for you. Symptoms are what you follow when you're looking for endpoint of treatment. So how do you know someone still has Lyme? The 4-week cycle. Symptoms that are migratory. It doesn't mean that the germ is driving around in the body. It means that it's genetically shifting and making different antigens show up in different body reactions. So look at someone who's saying, you know, my knee was 1 week, and then it's my shoulder, and then it's my headache, and then it's moving around. If the C4A was elevated in the beginning and it's still elevated, that's something you can follow. Obviously, if someone is off antibiotics and the PCR, culture, or antigen detection is positive, they still have Lyme. The endpoint is when the 4-week cycles disappear. That's why you have them keep a diary. Some physicians will say, when the 4-week cycles are gone, do for 1 more cycle just to be sure you didn't miss one. Now, what about this chronic Lyme? Can we cure it? You know, who knows? Is it even necessary? We all have pathogenic germs that don't make us sick because they're in kind of a symbiosis with our body. So I think that treating Lyme is like a balance scale. You weaken the germs with medications on the one hand, but you build the body up on the other hand using everything in your armamentarium. The vitamins, there's a whole long list of things that Dr. Horowitz will talk about later on. It's in my guidelines and so forth. But you want to get this balance. So you may not have to kill every last Borrelia, but just get them to stop having migratory symptoms, stop having 4-week cycles, and get back to the life that they like to lead. Now, are you all going to put someone on antibiotics for 52 weeks? No. Some practitioners do a 6 to 12-week course and stop. It's all right, let's stop and see how things are. If you need it again, we'll do it again. Some do give open-ended treatment, whatever you're comfortable with. I don't want you to feel like, oh my God, I don't want to treat Lyme disease, it's going to scare me off. Do what makes you comfortable. Over time, you'll get experience. And sometimes giving 6 to 12 weeks and stopping and reassessing might be a great idea. Maybe the patient doesn't need more. Or maybe you go into some complementary therapy at that point. Now, I want to close by talking about some very important topic, which is ignored by a lot of Lyme treating doctors. Do we have any neurologists in the office? In the audience? Yes? How many? Yay! Everybody's clapping, they don't know why. Chronic Lyme disease is primarily disease of the nervous system, okay? It affects the peripheral nerves, the central nervous system, and the autonomic nerves, and that's a real big area of disease in Lyme patients that's really very rarely looked into. So obviously peripheral neuropathy, there's numbness, the tingles, the dysesthesias, reflexes, and so forth. The chronic pain Lyme patients have that doesn't respond to narcotics. This is neurologic pain, okay, the lightning pains, cranial palsies, people don't have good gag reflexes, you know, the exocular muscles are out, physical weakness. Autonomic involvement, you can have tachycardia, the patients start having what they call panic attacks. They're not panic attacks, it's autonomic dysfunction. Increased sympathetic tone, the patients feel like they're caffeinated all the time, they can't sleep, they have exaggerated startle reflexes. Orthostasis, you have to check that, they can get syncopal. Poor gut motility. A very famous Lyme doctor wrote a book or an article called Bell's palsy of the gut. You know, vagus nerve gets affected. Neurogenic bladder, erectile dysfunction. You have patients, you have them take off their shoes and socks, and they're in a warm room, and their feet are ice cold and blue and purple. Well, they don't have peripheral artery disease, they have great pulses, the capillaries fill. It's because the nervous system is not functioning right, it's autonomic. So how do you document this? Electrodiagnostic studies like EMGs, nerve conductions, very low sensitivity. They're not going to pick up the small unmyelinated fibers peripherally that cause a lot of these symptoms and have effects on the autonomic nervous system. So what's done is a skin biopsy, usually of the lower leg. What you do is you look for and stain the nerve fibers, and you actually can count them and see what they look like. Also, you can do direct autonomic studies, heart rate variability, tilt table tests, sweat tests, and so forth. But these are things that really have to be done. And the very biggest gift a Lyme doctor can have is a good neurologist who's Lyme literate. Put your hand up again. Yes, there she is. Okay, this is very important. I'm just going to show you quickly, and I'm running out of time. These are actual skin biopsies from a Lyme patient. The top panel is a normal skin biopsy. The one on the bottom is not. Those little branching dendritic things, these are the peripheral unmyelinated nerves. Now, the unmyelinated nerves are in the skin, but they're also what run the autonomic nervous system. So if you see them disappear on a skin biopsy, odds are they disappeared everywhere else. Now, you also can do a sweat gland in the same biopsy. This is normal, and this is decreased. And if you see that, that raises the sensitivity of the skin biopsy by 100%. So it goes from 34% to 60-something% sensitivity. And you can see these abnormalities in people with normal nerve conduction studies. And the newest thing, which should be online within a month or two, and those who have questions about it can ask me afterwards, they're working on directly staining the peripheral nerves for myelin. So you can actually do a skin biopsy of the leg or arm or whatever, and under the microscope, there's demyelination. You've got it, 100%, right? You don't have to do an EMG or an MCV that misses 50%, 70%. The treatment for this is IV gamma globulin, which is very much underutilized. It not only can help remyelinate, it is anti-inflammatory without being immune suppressive. Now, Lyme is such an inflammatory disease, so well, let's give him cortisone to sort of calm it down, but then it makes the germs get worse. But IV gamma globulin will mediate the cytokine storm, get the immune system calmed down, and also help to heal the nerves. It makes a huge difference, success rate of over 80% in our studies, and it's definitely underutilized. Supportive things, the diet. You know, it's got to be a low glycemic index diet, low fat, of course. If the fats are in the diet, they have to be the high quality fats. Abstinence from alcohol. Alcohol, remember I talked about the balance between the spirochetes and the immune system? When you incubate spirochetes with alcohol, they increase the amount of toxins they produce. They make what are called heat shock proteins. So it makes the Lyme worse. At the same time, as we know, alcohol will inhibit T cell function and to some degree B cell function too. So here the balance is in the wrong way. We're getting worse germs and weaker immune system. So absolutely no alcohol at all. If you have any good wine at home, don't drink it, send it here. Never give immune suppressive therapy unless the person is already on an aggressive, hopefully IV antibiotic regimen. Now, I'm not talking about giving steroids to replace what's lost if adrenal function is low. That's replacement doses. I'm talking about giving, high-dose steroids for what might be MS, or high-dose steroids for what might be optic neuritis. Make sure it's not really Borrelia. And if you have to do something immunosuppressive, definitely use an IV antibiotic first for at least 36 hours before you start the immune suppressive drug. This also includes chemotherapy for cancer. I've had a number of cancer patients not get this treatment and have a lot of encephalopathy from Lyme. Others put on treatment and then didn't have any trouble. Put on antibiotics first. Now, we can go on for hours about nutritional supplements. What's on the list are the basics. A good quality multivitamin, hopefully USP certified. High-dose CoQ10. I'm usually talking about 400 milligrams a day. NT factor, which is the number one, along with vitamin D, thing that makes my Lyme patients say, wow, I feel so much better, and essential fatty acids. A number of you know that I've written for years and years my Lyme management guidelines. There's a very specific exercise program that all the patients need to do. And I can tell you point blank, if they don't do that program, they're not going to get over Lyme, okay, especially the chronic patient. The exercise program is not for reconditioning. It's not for physical therapy. It's specifically designed to enhance T cell function. Okay? Aggressive exercise inhibits T cells, but then they rebound afterwards. In Lyme, it's a different time schedule. I don't want to spend a lot of time on this because she's kicking me out. But follow the guideline. It's a whole body, non-aerobic toning program, usually every third or fourth day with rest periods in between, and gradually increase the interval, but never 2 days in a row. But I say, it's vitally important. The patients will not recover without it. They must get sound sleep. You're not allowed to let them get overtired. If they need to take a nap, they should. If they can sleep late, they should. If they have to work, they should take time off from work if they can. For example, take off a Wednesday afternoon if they can, to have a break midweek. If they have a good day, don't use that day to run around and do everything they should do. Use that day to rest. We'll hear from Dr. Bransfield about this too. And of course, the psychological and emotional support, not just for the patient, but the families, the caregivers. So many patients get alienated from their families. People should be the most supportive. They start to say, this you know. So get the family counseling in. We did it. Thank you all for being so persistent.